Integrative Headache Medicine of New York was sort of founded on the fact that I wanted an integrative practice that integrated all parts of someone's life into their treatment plan and really taking a precision-based approach. So there is no one size fits all. Everybody is different. So that was really what drove me to open my practice, and sort of the motto that I set and what I try to do with all my patients is give personalized precision care, taking into account everything that goes on in their lives. So not just medication and pharmaceuticals, but also how is their sleep? How is their stress? How is their diet? How is sort of everything impacting migraine? Because as we know, migraine is not just a headache, it's a disease and it takes over our entire life. So care should be comprehensive like that as well. Well, obviously, I think everyone goes into medicine for different reasons. For me, headache was a personal experience. I watched my mom suffer with horrible migraine attacks. I remember I would have to literally pick her up and put her into the shower and have the hot water go over her face. And she would just not take anything, not like know how to get better. And I always said, I'm going to help her and I'm going to figure out how to make her better. Little did I know at that young age that migraine is genetic and that at some point I would develop them too. So it was more of a journey and a quest to help family and help myself, but then really to learn about this disease that nobody necessarily takes seriously. I hate saying that, but it seems like there's so much misconception and it is so debilitating and so horrible in so many ways. And I just really wanted to understand it and really help everyone out there who is having trouble and feels misunderstood and feels like they can't get better, giving them hope and figuring out sort of how I can help people get better from this disease.
Right. I love that. And we certainly really appreciate having a doctor such as yourself. And honestly, I mean, I'm probably biased, but I definitely believe that the doctors who actually also have migraine are the best migraine specialists, right? Because you understand what it's like. You're not going to just say, oh, just deal with it or just toughen up or just kind of push through. You really get how debilitating it can be. And for many of us, that actually becomes so much worse during perimenopause. And then even once we go into menopause, it's not necessarily stopped. So that's what we're talking about today. But why don't we start with a couple of definitions? Because people throw these terms around, kind of willy-nilly. So could you please define perimenopause and what age range this normally happens, and then define menopause as well?
Absolutely. As we know, this is the hot topic and defining it's super important. So perimenopause, peri basically means around menopause. So it's this transitional phase when the estrogen and progesterone levels start to fluctuate and become more irregular. It can begin as early as your late 30s, early 40s, and lasts about 4 to 8 years on average. And it's the time where everything is fluctuating. So I always say migraine likes stability, but it's the time of the least amount of stability where everything becomes irregular. And that's also what makes migraine become more irregular, unpredictable, and can make it worsen.
Right. Absolutely. So what kind of age is there? Like, I know it really varies from person to person, but how early can it start? And when does it generally tend to stop and you move into menopause?
I love that question, and I wish I had the exact answer. What we were taught in medical school is not what we're learning now, is that really you're in perimenopause. Even in your late 30s, things start changing. When it actually transitions to clear, like perimenopause, where you would have perimenopausal symptoms, I think it all depends on how close your body is to when you're going to go into menopause. The average age of menopause is around 51 in this country. So it really also depends on your family and your mother. I would say look to your mother as to when she went into menopause. But I think we all start having changes as early as our late 30s, early 40s, and then just depends on when symptoms develop. I don't have a exact answer, but I think there are changes starting earlier than we ever recognized.
Right. That's actually very interesting you say that because a lot of women are still having children, right? They're still going through pregnancies during that time. And so we see that a lot of women, their migraine attacks get worse after pregnancy, but that could also be touching on the beginning of perimenopause as well, right?
Absolutely. I feel like as we start having children a little bit later, our bodies are still working. We're still able to reproduce. It's just that the hormones are shifting slightly in different ways. And I think there's a huge overlap as to what is perimenopause, what is postpartum, what is life, what is not sleeping. There's so many symptoms that overlap that a lot of times it can get confusing.
Right. Like everything migraine, it's just complex and we're all different. which makes it challenging for sure.
I know. I was just like, am I having night sweats because I'm having perimenopause or because I'm
Right,
just sick? Or I
right.
like it's really sometimes it's really hard to tell, even for us doctors.
Right. No, that makes total sense. So I know this is going to drive you crazy because I'm going to ask for more numbers that you can't necessarily give precisely. But in general, what percentage of women find that their migraine attacks get worse during perimenopause?
Ooh, I'm again biased because I see all of the women and I feel like whose migraine get worse around perimenopause. I would say around 60%. I would about 60% of women get worse around perimenopause. I think it depends again on the person and depends on how their migraine attacks were leading up to perimenopause. But yeah, I would go that the majority.
Right. Is it, do we have information on if someone has menstrual migraine, like they know they're going to get a migraine around their menstrual cycle? Does that make it more likely to get worse in perimenopause, or we don't have that data yet?
We do, and unfortunately, yes, it for women who have menstrual migraine, they're much more susceptible to the fluctuations in estrogen. So the hallmark of perimenopause is fluctuations in hormones. So we do see that women do have a worse time around perimenopause if they have very clear menstrual migraine.
Sure, that makes a lot of sense. So then moving on to menopause, which is after a woman's cycle has stopped for 12 months, right?
Correct.
And they're officially in menopause, then what kind of percentage will actually get better? Because we see this all the time. Doctors telling patients as soon as you get into menopause, life is going to be great. And for so many of us, it's not exactly true.
I feel like those absolutes are very frustrating. It's like you're going to get better. I have women who are like, I'm waiting. I went into menopause. I'm not better. Oh no. But around two-thirds of women improve after menopause. So definitely not everyone. And it's especially, but this is where having menstrual migraine is helpful because especially for those people who were more triggered by hormones, the hormone stabilization phase that comes after menopause is helpful for those
Right.
patients.
Yeah, that makes a lot of sense. So, can you explain a little bit about why these hormonal fluctuations impact migraine attacks?
So we can blame estrogen. Estrogen has a really powerful effect on our pain pathways, on serotonin receptors. And when estrogen drops rapidly, like we're thinking before a period, and or it's erratic during perimenopause, the brain's pain threshold lowers and it just becomes much more susceptible. So again, it's the estrogen dropping before the period, but think about it's drop up and down and up and down around perimenopause. It just makes everything chaotic.
Right. That makes a lot of sense. So looking at all that, then we're going to kind of move on to questions about diagnosis and treatment. Is this time during a woman's life, whether she's in perimenopause or going into menopause or in menopause, are the migraine attacks best managed by a headache specialist, an OBGYN, both of them together, or another type of clinician?
I will always say headache disorders are best managed by headache specialists, but I think it has to be in collaboration with OBGYN as well. Because I will say I know a lot about hormone replacement. I know a lot about hormones, but I would still defer to my OBGYN colleague to talk about the hormone strategies after I've given my diagnostic impression and my plan. So I think the first step is seeing a headache specialist and saying, okay, here's what's happening. Can we relate this to the perimenopause menopausal transition? Can we treat it with our standard migraine medications? And then if we need extra support, then how can the OB come in and support that with more of a hormonally based approach?
Sure, that makes a lot of sense. We actually have a question come in live just now, and plus it was a question we got beforehand. So this person wrote to us ahead of this event. It said, I suspect I'm getting perimenopausal migraine attacks. How can I get an accurate diagnosis? And should I get a complete hormone panel? And then one of the people who just commented here says, at least she has migraine attacks at least every week. She's 49, not sure if she's in perimenopause. So is there a way to know for a woman if they're actually in perimenopause?
It's clinical. So it's based on your history, on your symptoms. There's no blood test that's going to tell us. Yes, blood tests can help knowing once you're in menopause, but a lot of people want hormone panels. They really want to know. We all want to know what's going on with our body, right? But the hormone panels are not going to tell you. So I say tracking symptoms is the most helpful. Definitely looking at period, your periods. Are they becoming more closely spaced together? Sometimes the cycle goes from, you've always had 30-day cycles and now you're at 25 or you're at 21. Are you bleeding more days in a row, less days in a row? How is your sleep? Are you having hot flashes? Are you having brain fog? Are there other symptoms suggestive of it? Because it's, like I said, it's a clinical diagnosis.
Right, that makes sense. I remember my OBGYN saying, we're going to do a hormone panel on you, but 2 hours after we do that panel, it could change, so it's just a matter of where you happen to have your blood drawn. So not particularly all that helpful. So
Yeah.
are there specific types of hormone replacement therapy that are considered safer and more effective for women with a history of migraine? And does that vary whether you have migraine with aura or hemiplegic migraine or other types of migraine?
Yeah, and I think this is where the personalized precision approach really matters. We know that transdermal estrogen, which is what's usually used with hormone replacement therapy, tends to be safer and also more stable for those with migraine than oral estrogen. Thinking about stability, you're having a patch that stays on its consistent levels instead of the spikes and the drops that will come with an oral pill. For women that still have uterus, progesterone also has to be added. And we say that the natural form is usually better tolerated, but progestins usually don't have a huge impact on migraine. The biggest thing is we usually say to use the lowest effective dose of estrogen and contain steady states rather than cycling of any hormones. So that's usually my go-to. It's an estradiol patch at the lowest effective dose. And I don't necessarily expect it to make migraine better. I think that's sort of where it comes in. It's more using it as a hormonal support for the other symptoms. Sometimes we do find that it does help migraine, but not in everyone.
Yeah, absolutely. So we have someone actually asking the question. First of all, they want to know, do you do virtual visits? Do you treat people outside New York State? I'm just going to add that in as well, since that's relevant. So maybe you could quickly answer that, and then I'm going to tell you what else she says.
So I am licensed to practice medicine in New York, New Jersey, Florida, and California. So virtual visits in those states. I can also, I can't practice medicine, but I can give consult virtually. And then if you decide you want to come, you can come in person.
Absolutely. That sounds great. So if maybe, Lorraine, if you could put that link to Dr. Natbony's website in the chat, that will be great. And we'll also send that out to people afterwards by an email so that you have it. So the question was, for those who are not able to do anything hormonal,
Yeah.
and that's obviously a question that we had ready for you, is what are the other options for best managing migraine? Or is it still literally just a personal thing you have to try? Excuse me, you have to try all the different treatment options.
Can I just ask just on that question, is it that you can't use hormones because of aura or because I wanted to go back and answer
Sure.
the aura question as well. Because I think there's different schools of thought on this. And actually, we recently debated this at the American Headache Society.
Right.
So we do know that estrogen patches, the transdermal form, is a lot safer versus the traditional oral contraceptives, just because they're much lower dose, they're steadier states, and they're more like our own innate estrogen that we have. It's just a better supplement to our own levels. And we don't necessarily know if you're going into menopause, right? Think about it. Your own estrogen levels are going down, and estrogen is by itself a risk factor, is a vascular risk factor. So we're all walking risk factors. We're then supplementing with estrogen to get us back to a normal level. We're not looking to be supra therapeutic, we're looking to normalize. So, is normalizing back to a normal estrogen state actually more of a stroke risk factor? I think we don't know 100%. We definitely know that the transdermal estrogens are a lot less of a risk factor. And I don't, in my practice and looking at the literature, I don't say that you can't use hormone replacement if you have aura. I usually look at what are the patient's other risk factors for stroke, making sure that if they have any others, then I'm going to tread a little more carefully. But it is still something now that I will broach with patients. And I think it really just depends on the context, and it shouldn't be an absolute no.
Right, that makes total sense. And it's such a hot topic. Like we actually had somebody post about migraine aura. They posted some images of what it kind of looks like for them, and it was only posted yesterday evening. We've already had almost 600 comments on it, and it's just like
Wow.
it's just going crazy because it's such a hot topic. You know, people are
Yeah.
saying, "Wow, this is aura," but now does that impact what I can do in terms of treatment? You know, but outside of aura, with hemiplegic migraine, for example, is that or any other types of migraine change what you can do in terms of treatment?
I think it really goes back to depending on the individual person. And like I always say, everything is a risk benefit. Crossing the street, we take a risk every day when we get into a car. Everything has a risk. It's talking about, do we have numbers on that risk, being informed of the potential risk, and then choosing our options. So I truly believe that there are very few things that are 100% no. I mean, yes, there are things that are 100% no, but it's really informing and talking with the patient and about their preferences and also what is the most bothersome thing. Because if you're living life but you're miserable all the time, what's the point? It's better to discuss what the alternatives are.
Yeah, absolutely. And that makes total sense. And I try to explain to my friends who don't have migraine what it's like for me, even when I get an attack, trying to decide what should I take, you know, and that risk benefit, you know, what is safer, what's going to have side effects. Am I willing to deal with those side effects? You know, and that's very challenging, right?
That's me. I
Yeah.
feel like I've been asked the headache doctor. I'm like, do I take this, like that, or take nothing because I'm a terrible patient? But I feel like it's always trying to calculate those risks. And what headache doctors and why I'm here is try to help to make that clearer. But I think there is sometimes no right choice. It's making the most informed choice in the moment. But you
Right.
also asked about other treatments. So there's none of our regular prevention that necessarily has more evidence for being used around perimenopause. It really is finding better prevention or adding on to a prevention regimen and being a bit more aggressive. So what I tend to find is someone comes in, they were doing well on their prevention plan, but then I need to augment it with something else. So I usually augment by saying, okay, if you're on a beta blocker, maybe I'm also going to add a gepant or a CGRP monoclonal antibody, or maybe I'll add Botox on top of that. Or it's layering more in my experience, not necessarily just leaving it at that single thing or changing it to something else. I feel like I more need to pile on.
Right, absolutely. I think one of the most frustrating things we actually see in our community is people coming in and saying that their doctor just put them on one pill and they're expected to get better. And, you know, then what do you do when you get an attack and you can't stop the attack? And it's so we talk about that toolbox kind of approach, right?
Toolbox, the plan,
Yeah.
basically the prevention plan and then the acute migraine action plan. I feel like there should never just be one step and always just making sure that with prevention, I think a lot of times we don't maximize the prevention. We sort of just stop when it's no. I mean, the
Yeah.
trend is to say, it's good enough, or you might have side effects at higher dose. But a lot of times there's so much more room and so much more benefit that could be gotten out of medication. So that's something I always look at when I'm seeing patients is, okay, if you're on something, are we getting the maximum benefit out of what you're on? And dose-wise, are we at an appropriate dose?
Right, absolutely makes sense. So one of the questions we have actually from someone called Kelly is asking again about not being able to use hormones. They had breast cancer previously. Is that a common thing if you've had breast cancer that you're told you should not be taking hormones for migraine?
Usually, I think that is definitely more of a tricky situation and one where I think again, risk benefit, but I think the risk there is probably a little bit greater, but it's one that I would definitely, as a doctor, be talking to your oncologist, be in communication and talking about what the options are. But there, I would definitely be trying to maximize my non-hormonal options first, and really being much more aggressive in that stance.
So let's talk about some of the other options we have besides medications. Could you maybe discuss the benefits of supplements like magnesium, CoQ10, vitamin D? You know, are those supplements going to be helpful for someone going through perimenopause or in menopause? Or again, it's totally personal. Is there any supplement that I've missed out of that?
Supplements I use all the time as part of a prevention plan. I think that there's no supplements don't become more beneficial during perimenopause than they would
Right.
be at other times. We do know, for example, that magnesium is great for migraine prevention, and then it's also great for menstrual migraine because we do know that magnesium levels shift more during hormonal fluctuations. So it is one that I tend to be a little more aggressive with around perimenopause just because if there are fluctuations in hormones and it's helping sort of just to stabilize, then everyone should be on magnesium. It also can help with the nighttime, the sleep problems. It could help with sort of some of the other symptoms. For the other supplements, there's no clear evidence of that around perimenopause is better than others, but I think there is a great role for supplements as they are most commonly safe. It's just how effective they are depends on where you're starting from, right? Like I don't expect someone who has 20 days a month of migraine to start taking a supplement and be down 50%. But I do think it is part of the toolbox. But I don't have one specific one that I would say that's the one to use around perimenopause.
Sure. Then what about the treatments like herbal treatments? So we know that a lot of women are having hot flashes, right? They'll take herbal treatments to try to manage that. Is there a chance that that can also help manage your migraine, or really there's no herbs that we should be looking at?
Which herbs specifically are you
So,
thinking
and
of?
I'm very much aware I'm saying that in the English way, herb. We don't drop the H.
Okay.
So it's like, I think like maybe the cohosh, or like there's a company, Feminescence, that has
Yeah.
different mixes of herbs that you can take. I mean, I took one of those myself for the hot flashes. Never found that it helped my migraine attacks, but helped the hot flashes. But, maybe that's not the same with everybody else.
So, as we know, the brain is very much intertwined. I would say there's no evidence that these substances help with migraine, but a lot of time migraine is triggered by the things that are also happening during perimenopause. If you're not sleeping, you're having hot flashes, that could be a trigger. So, if you're treating that part of it, then as sort of a downhill effect, 100% can help migraine.
Right. Absolutely. And then let's look really quickly at medical devices. I know that I didn't tell you ahead of time I was going to ask this question, but just as part of that toolbox, what are the FDA cleared medical devices for migraine that are actually out there that we could also use that are not hormonally related to help manage migraine?
I love devices. Everyone knows
I
every
do too.
single one of my patients gets a device because it's sort of one of those, why not? It's kind of an added bonus. So I'll start with Nerivio because Nerivio, I feel like is the easier one to use. It was recently FDA approved for age over 8. So it's good for the whole lifespan. I know we're talking about perimenopause and menopause, but also can get the kids started on it young. Um, I I always recommend that the patients to use it for rescue as part of their sort of multi-tiered approach to rescue, and also can be used as prevention. That one I like because you can wear it under your clothes. I can be sitting here right now and you wouldn't even know that I was using it. Cephaly is another one that I really like, worn on the forehead. If you tend to be someone who has a lot of pain in the front of your head, I think it's a good option. There's also GammaCore. There is the Savvy Dual, which is a transcranial magnetic stimulator. We also have the Hedaterm, which is similar mechanistically to Cephaly. And then we have Relivion, which is kind of Cephaly plus the occipital leads. But yeah, there's a lot. There's a
Yeah.
lot. And I think that it's all about actually doing it. I feel like I know that's like I love devices, but I find a lot of the time as we discuss a device and it's like, but that's a lot of time to do it. And nothing is going to work if we don't actually have the time to incorporate it. So I'd say if you're a person who can dedicate the time to use a device, please do it because it can be really, really beneficial. And that might be maybe you're on the pharmaceutical and just adding the device will be enough to help get you through that perimenopause transition. You might not need another medication, but it's just commitment to using it.
Yeah, it's definitely worth trying. And unfortunately, migraine can be incredibly time consuming, right? I mean, it really destroys our lives and steals time, but then the treatments can also steal that time as well. So,
No.
it's a catch 22 trying to figure out what to do. We did have one quick question about magnesium. So just to back up to that, which type of magnesium is best? We get asked this all the time in my community, magnesium threonate, citrate, glycinate, and I know there's others out there as well. What's your recommendation for that?
I typically recommend magnesium glycinate just because it's the most bioavailable, so it best crosses into the brain. It's also the best tolerated. I find that magnesium oxide, magnesium citrate can cause more loose stools. If you have constipation, no problem. But if you don't. I just feel like I can't get the dose up necessarily as high. With the goal dose being around 400 to 600 milligrams a day, most of the trials actually looked at the higher range of doses around the 500 to 600 milligrams a day. So I can usually get there with the magnesium glycinate. So yeah, that's the formulation I recommend.
Okay, that's great. And then actually another person asked the same similar question on it, part of which you already answered, but is it best to take magnesium tablets? I know you can also get magnesium in drops, and then they're asking about the magnesium IV infusion.
I would say for the oral form, it doesn't matter which way you take it in, just making sure you're getting the appropriate dose. Because a lot of times, if you're doing drops, you have to take a lot of drops. I also want to point out that a good quality magnesium, again, this is not that you can't get a good quality magnesium in one pill, but to get 600 milligrams of magnesium in one pill is very challenging. Usually it's going to be multiple pills. So you have to take 4 pills to get that amount. And I know that could be pill fatigue. So just making sure that you're getting the right dose because it's usually never one pill and that's the
Right.
correct dose. IV magnesium has good evidence for status migrainosis, for breaking a prolonged attack. I think it depends on who you talk to in terms of is magnesium helpful from IV magnesium from a prevention standpoint. I don't usually recommend standing IV magnesium over and over. I feel like the if you're supplementing with a pill, great. You could always augment if you need to with the IV or if you're in the midst of an attack.
Right. Absolutely. That makes total sense. So thank you for that. We're going to kind of move on to my lifestyle questions. We have a couple of live questions about that. So one
Yeah.
person says, I'm 72. They went through menopause or perimenopause early. So they're in menopause. And while going through menopause, I think maybe she means going into it. She had horrible headaches. And then 4 years ago, started with the migraine, dizziness, vestibular migraine. Is this normal for someone who has not necessarily experienced that earlier on in their life to suddenly start getting this once they're going into menopause and then once they're in it?
Yeah. So first to say vestibular symptoms are much more common postmenopausally. So I see a lot more women presenting with vestibular migraine than we see at a younger age. So yes, that is something that is not uncommon. I also see, and we know that migraine in women has a bimodal distribution. It peaks around the reproductive years, but then again after menopause. Just because fluctuations in hormones are a trigger doesn't mean that hormonal stabilization and the lack of having the hormones isn't part of the migraine trajectory. So, yes, unfortunately, migraine can start all on its own after menopause.
Right. It's good to know. I mean, not good to know, but it's good to be informed that that
Yeah.
can actually happen. So, similar kind of question asking about the hormones again. So, someone is asking, can you start estrogen after 60? I don't know if there's an age kind of cutoff. And then she just added that dermal estrogen actually triggered migraine attacks for
Yeah.
her. Is that also possible?
Absolutely. I think we always think about is estrogen going to help, but it can go both ways because just because you have fluctuating estrogen, giving more estrogen is not always going to help. So yes, I definitely see that. And I've also seen patients come in who really didn't have migraine before, were put on hormone replacement therapy and now have horrible headache from it. So I think that it's not a panacea. It's really dependent on the person, but I would say I have a bunch of patients who have stopped it because it's made things
Right.
worse.
Absolutely. So actually a question that we don't have here, but I just kind of occurred to me, was we've heard that some OBGYNs will say, just have a hysterectomy, and then that's going to solve your migraine problems during perimenopause. I actually had my OBGYN said that to me. Thank goodness I did not go ahead and do it. But maybe you could speak into that and the chances of that making things worse rather than better.
Okay. I just want to clarify, hysterectomy means that your uterus is out, so you still have hormones. And you would have to have a total hysterectomy with
Right,
oophorectomy, meaning your ovaries get taken out as
right,
well to have an impact. So that's what I'm going to talk about if you've had everything taken out. So imagine that you are walking and all of a sudden your legs don't work anymore, for example. Like it's basically your hormones are working, you abruptly take them away from you, everything changes. It's the biggest shift that is so abrupt. It is the worst for migraine because basically you don't have the cycling anymore, but it is an abrupt change that your body is now going from having hormones to nothing, and it doesn't help. We know studies have shown that actually taking out the ovaries and actually does absolutely nothing, if not worsen migraine. So I would say if you're going to do that for a medically necessary cause, absolutely. For migraine, please don't.
Yeah, please don't. Absolutely. That's what we tell people in our community, that we've been told by headache specialists. So it's good to actually hear this on this interview as well. Because we get told, I mean, and I know you know this, we get told so many crazy things by doctors who had not been trained in headache medicine and may not have had any education in headache medicine at all. And so it can be hard for someone to understand that just because your doctor says it doesn't actually necessarily mean it's true if they're not educated in this area. And that's a
So
frustrating
true.
thing.
It is. It's really frustrating. I can only imagine.
Yeah. So we have a person who wrote beforehand. They said they're in menopause and they feel more anxious and depressed than before menopause. And obviously, we know this affects migraine. We also know that migraine can cause that, and some of the medications we take can mess with that as well. What is the best way to manage this in the midst of perimenopause or once you're actually into menopause?
So mood affects everything all the time, but especially in menopause with all of the hormonal changes and also the life stage changes. I feel like mood, anxiety can all get worse. So I always recommend talking with your primary doctor, seeing a psychiatrist, seeing a therapist. And we know that there are also medications for mood that have an overlap with migraine that could be helpful. But I would say aggressively treating the mood is the most beneficial thing you can do for migraine because it really does help by taking away the trigger. Again, it's not the cause. We'll never say mood is not the cause of migraine. It is a factor that can contribute because there are shared chemicals. So being aggressive in treating it is the next best step.
That's helpful to know. A question that just came in, and by the way, we are able to still take more live questions. So if you have a question, please put it in there as soon as possible. This person is asking about navigating this time of life while on birth control, such as an IUD. So if you use an IUD to manage painful periods, how do you know? Are you in perimenopause? I actually was asked this a few days ago. Am I in perimenopause? Am I not? Not like I can answer it, but someone was sharing that with me. How do you know what to do if you have that IUD or you have an implant for hormonal control?
You won't know, but I think part of the thing about it is if you're not having symptoms of perimenopause, then it doesn't necessarily change anything. I was actually told by my OB that I was like, I asked the same question. I was like, if I have an IUD, how will I know? Because especially with things like Mirena, usually periods stop. You don't even know you're getting your period anymore. But she was actually telling me that it will help ease the transition into menopause because you will have the progestins that are protective and actually will be a smoother transition. I had not thought of that before, but it actually can help with some of the perimenopausal symptoms. I think the thing is you might not know. We might not know, but is it okay not to know if we're not struggling with it? Yeah, if you notice that everything is getting worse, migraine is getting worse, it could be perimenopause, but it also could be something else. So the first step is always going to be to obviously talk to your doctor and talk about optimizing your treatment. But I think a lot of times it's trial and error. We're not sure if it's perimenopause.
Right. So if you have significant menstrual migraines, this is the live question again. So I just throw all this stuff at you, but it's just so fabulous. Your knowledge is just incredible. So appreciate it.
Oh, of
Um,
course.
so this person's saying their doctor's recommending removing everything but the ovaries, which you mentioned. So if in that case, would that not impact your migraine attacks? You're not gonna go into medical menopause if your ovaries are left, right?
Right, but what is the reason for removing the uterus?
Endometriosis and ovarian cysts.
Okay, I feel like it shouldn't affect it. The ovaries really are what the important part is for surgical menopause.
Right, absolutely. That's great. Now, we haven't really talked about this, but the role that lifestyle factors play. So when we're talking about that toolbox with the medications and the devices and supplements, there's also diet, sleep, and exercise. What kind of role do these play while you're going through the perimenopausal symptoms and then once you're in menopause?
Lifestyle is basically the foundation of everything. It's something we should always be working on, but I do believe becomes harder as we get older. Because consistency, if we think about the pillars of lifestyle, the pillars of my integrative plan are regular sleep. If you're having hot flashes, not necessarily going to be having regular sleep. You want to have regular meals, hydration, exercise. I do think that exercise is something that is even more important as we get older because an inactive body has a harder time becoming active. And I know having migraine and age, I sort of everything can contribute to the lack of exercise, but that is one that I tend to push pretty strongly. Also, trying to practice more pacing, like pacing ourselves. I feel like also in this age, it seems like it's everything is going on all at once. And I think trying to use some techniques to slow down, feedback on ourselves, trying to find some activities that are calming is really important because we do know, right, that the mind body techniques, biofeedback, yoga, meditation have been shown to lower migraine frequency. And I think this is a great time to put them in. I will say, again, a very hard buy-in, but I do feel like this is the prime time to put it in because it can set you up for success in the future.
Absolutely. That makes total sense. And, our community, we're always encouraging people to talk to their doctor, not just kind of keep pushing through, but let them know what is going on so you can put together a plan sooner rather than later. Like
Yeah.
pushing through is not always the best thing. And most of the time, I would say it probably isn't great. But then you're looking at the risk benefit, thing.
Exactly. I was going to mention acupuncture. So like you said, I am a trained acupuncturist. I am not currently practicing acupuncture because I spend a lot of time with my patients on other things, but I feel like it's a great skill to know. But I will say that this is where acupuncture can be helpful for both the perimenopausal symptoms as well, because it can help with the hot flashes. It can help with sort of balancing the whole body and might also help with migraine. So this might be a good place to put in acupuncture.
Right. Yes, and that's good to know that it's not necessarily going to be like the cure all that you're hoping for, but just together with everything else, it may be beneficial, right?
Yeah.
So, what would you say is the best way for a patient to track what is going on so that they can give you helpful information? I think most of us with migraine have experienced, sitting in front of our doctor and they're asking, how many days did you have attacks? What did you take? What are your symptoms? And our mind just goes blank, either because you're just being faced with it the last minute or you're on medications that can also cause brain fog or migraine. It causes brain fog. So, what is the most important information for patients to provide you with during this time of their life so that you can best help them put together that toolbox?
I'm a data nerd, so I love love data, but I also think it depends on what is your doctor going to look at? And I think the high yield is basically tracking, putting a check mark on a day. You have a migraine, tracking your period and your cycle. I always just say just put a P on a calendar so you can see if there is any correlation, and then tracking if there is any hormonal symptoms that are happening at any time. But again, not right. You don't have to write a lot. It's just basically like if you have a hot flash, put that on there. If your sleep, put that on there. But really just keeping it simple because the more complex it is, I find it doesn't help in trying to track everything all at the same time. And it just never really gets done. So my best advice is on the notes app on your phone, for example, I write the date when just write the date down when you have a headache, and then just write the dates of your period. And then if you can just do one thing, just do that and then give those to me. And then at least I have some framework of what's happening.
Sure. And obviously, the best thing is going to be the thing that you're actually going to do, right? There's no point having
Exactly.
an app if you don't open it up and you don't complete all the data input. So we mentioned kind of a migraine action plan earlier on, and our organization has a migraine action plan that we sent you, for your review last year, which talks about all the different ways that you personally are being suggested by your physician to manage migraine from preventive all the way through acute and then multiple acute scenarios, right? What role does an action plan like that play? Do you think that that is helpful for patients to have? Is that helpful for doctors to have when they're looking at their patients?
I would say one is a plan not helpful because I think a lot of what happens is this anticipatory anxiety over what do I do if? And I even think to myself, I hear patients say, if I take that medication and it doesn't work, then what? So then they sort of get stuck in not wanting to because then they don't have another option. So what a migraine action plan does is it gives a clear breakdown of here's what you should do. I always have a step 1, a step 2, a step 3, sort of in an attack. So if something doesn't work, we have a backup, and we have a backup to the backup. Then if all else fails, we have our emergency plan. So it feels like the doctor is still with them or with you, guiding you through, even if they can't be there. Because I don't know how many times patients have called or try to get through their doctor when they're in the midst of an attack, and just that communication, it's hard. So having a clear plan is important, both for the patient to feel a sense of sort of just preparedness and feeling confident, and also for the doctor to be able to know that their patient will do all of these steps, and then they'll be able to have feedback on whether it worked, whether or not, so the plan can change if it needs to.
Yes, absolutely. And I'm sure it's not helpful when patients are like all calling the last minute, help, my medication's not working. If they had an action plan, they knew what to do for that next step, then that's going to kind of help offset that, at least in some situations, right?
But
And hopefully
I will
keep people
also
out of
say
the
it's
ER.
not that patients can't call. It's that sometimes we honestly, as doctors, we don't know what I'm going to
Right.
put out there. I'll sometimes say, I'm doing terrible. I took everything. I don't feel good. I'm like, well, what is everything? And what exactly did you do? And it's a lot harder when you're in the midst of pain to actually track what you're doing. So if you said, I followed steps 1, 2, and 3 of my action plan, and this is where I am, it's a easier reference to then for the doctor to know what to do next. Because sometimes we need that information to know what the next best step is, and that's a way we can get it.
Yeah, I love that. It really helps the partnership between patients and
Exactly.
physician. And so for those people interested in downloading a migraine action plan, we can put a link in the chat right now, and we'll also include that in an email. You could just download it from our website, take it into your doctor, talk about it with your doctor so that you actually have a plan for moving forwards. And if you're seeing a doctor who does not understand migraine or not educated, then we've had other doctors say, get a second opinion or go see a headache specialist. It's so
Mhm.
important to do that. So I'm on the final question now, and this information has all been incredible. Also want to let people know that this is part of a project we're doing right now, so there will be a lot more social media posts coming out in the next couple of weeks. So ask you just to kind of tune into our online community and our website for that. But as we close, Dr. Natbony, what is the most important thing you would like to leave with people as we wrap up this webinar?
I think I always say not to give up hope. And I really just want to say this is the time, I think, of life of perimenopause, menopause, where everything is just fluctuating. And I feel like people just say, you're just aging. This is just part of life. This is just getting older. You don't have to settle for that. You don't have to settle for this is just aging. There are tools and there are treatments that can help. It's just finding what precisely works for you. So basically, migraine is treatable. I know that not for everyone to the same degree, but that just because you're going through different stages of life shouldn't mean that you shouldn't be getting the best care, and it shouldn't mean you should just age this way. There are so many things that we can do to help. So,
It's
yeah,
really great to know that. I mean, we know migraine is really, really challenging, but there really are so many options to help now for people. And so not just kind of putting up a second best is really important.
and one more thing I want to say is that for women, you are not imagining things. I think a lot of times when we're like, I have brain fog, I have this, and I think just to say it is real things that are happening. Your brain is responding to real biologic changes. So you are right. You know yourself. So just take, like, I guess, oh, what's the word I'm looking for? Just as a woman, I feel like a lot of times we could be gaslit into thinking that these things aren't happening. And I just want you to know, I see you. It's real. It's happening. And just own that. And yeah.
I love that. I see you. It's real. It's happening. Just that verification can be so huge. So thank you so much, everyone, for being with us today on Migraine Meanderings. We will get this up onto YouTube, hopefully by the end of the day tomorrow. I hope that you've all found this helpful. If you have questions that have not been answered, please let us know. You can email us at info@migrainemeanderings.com. You can go onto our social media sites. You can go onto our website. You can chat after we post this video as well. And we'll try to get you those answers if we haven't already done that. Migraine can be such a challenging disease to live with. And so we encourage you to proactively partner with your doctors, explore different options, and create together with them an action plan to help manage your symptoms. Thank you so much for joining us today.